live on Facebook. Okay, we're live in two places. Right, streaming has been initiative and the recorder has started. Don't try this at home, folks. We are trained professionals. Right. Cynthia Levy, good afternoon. How are you? It's really nice to see you again.
Hi, good afternoon, Robert. Good to see you.
So it's a pleasure. So if you've never seen now, she says Dr. Levy. So Dr. Levy for short, in the sense that she sees patients on a regular basis. She's also Professor Levy, who is a teacher, mentor, and leader within the PBC community, just as one branch of her work. All in all, an eminent world expert and a proven track record of patient centricity. Now that I've stopped talking about you, I can talk to you and say welcome. Always delighted to work with you. So we have lots and lots and lots of questions, but my first question, so I know that we're working together in a symposium at EASL in June, and I've just seen you at the DDW. So DDW is Digestive Diseases Week. So my first question, I guess, is, conferences, how important they are, and what's the benefit in terms of sharing the information that we need to get to the audiences that we're trying to reach at the moment. Is there anything you can say about that, please?
Sure. Well, first, good evening, everybody. And I really want to thank you and the PBC Foundation for the opportunity and for being flexible with my schedules, because I know this is
Oh,
not your usual meeting time. So thank you, everybody who could make it. So the meetings are super important in so many levels. First of all, it's something that we enjoy doing, and we should all do things that we enjoy. But it's a great opportunity to teach other physicians who are not as familiar with PBC as we are, right? And as many of you in the call now know, sometimes you will see a physician who doesn't feel as comfortable because they have one or two patients and they don't know all that's coming up. So this is my chance to educate my peers. Of course, I'm going to be educated on a lot of other things, but it's my chance to teach people to answer day-to-day questions. And at the same time, we advance the science during those meetings, because that's when we meet with we're designing the clinical trials to make them patient-centric, as Robert is saying, to make them as, you know, as, as best as we can to improve patient participation and have good outcomes and benefits for everybody. So that's it: scientific development, educating my peers, and clinical trial design. So, and some of these meetings, not all of them, have plenty of opportunities for people living with PBC and their caregivers to also participate in the meetings. I know ASLD is making a tremendous effort to have forums
yeah,
for patients during our scientific meeting. And then during ESO as well, we have this symposia that running parallel with the scientific meeting also allow for this interface, this interaction between the clinicians and the patients, so you can voice your experience and ask your questions.
wonderful. Okay,
Long
thank you. Good answer. So good, thanks. Thank you very much. Right, we have lots of questions coming in. We've got people already in Facebook who have asking questions, which is
I'll do
fantastic.
my
So
best.
I'm going to start right at the beginning, because one of the hot topics that comes up on a regular basis is diet and PBC. And there isn't much out there in terms of scientific data or anything else that we can point to. But if people were to ask you about a PBC specific diet or anything they can do in terms of their input, how can they help their PBC? So, what can you offer?
Yeah, that's a great question, because it is one day-to-day concern. However, as you pointed out, there is no data, right? There's no PBC specific diet. We haven't been able to come up with that yet. Now, what I can tell you is, in general terms, 1/3 of the world population has fatty liver disease. So it's very likely that a third of my patients with PBC who will also have fatty liver disease. So a healthy diet in general terms is what people living with PBC should follow. There's no PBC specific therapy. So assuming you don't have advanced disease or decompensated liver disease, which we can talk about in a moment. Assuming that's not the case, in general terms, is keeping your health in good terms. So low saturated fats, low carbohydrate diet. In general, if a patient asks me what's the one diet that you recommend, the Mediterranean diet is the one that has been shown to have cardiovascular benefits. And there are a lot of studies coming up for that diet in people with fatty liver disease as well. So based on a lot of plants, so vegetables, whole grains, right, and less of the saturated fat. So in general terms, that's it. Alcohol use is not forbidden, right, unless you have cirrhosis. And alcohol in excess can cause damage to everybody, not just people with PBC, everybody. What's recommended safe? Less than 7 drinks a week for women, less than 14 drinks a week for men, assuming you have a healthy liver to begin with. If you have disease, you want to be more gentle with that, right? But it's not forbidden. You can have an occasional glass of wine if you don't have cirrhosis. Now, I mentioned that patients with decompensated or more advanced disease may have some other limitations, right? So in that sense, if you are suffering with fluid retention in your abdomen or your legs because of cirrhosis, then we also recommend a low salt diet. And by low salt, we mean less than 2 grams a day. So you're going to count every serving of everything that you have and see how many milligrams of sodium and subtract that from the 2,000. Right? So that's the only limitation if you have more advanced disease. And of course, the alcohol issue. Coffee is good for the liver. No cream, no sugar. So black coffee, 3 cups a day has been shown to reduce inflammation. And there are even studies showing lower risk of cancer with coffee intake. That's as far as we can go with diet.
Okay. No, that's helpful. Thank you. So there was something that you said there. So this is to do with the fact that there's no restriction on alcohol, fatty liver disease, which has a slightly different very different mode of creating damage within the liver. Would you be happy just to talk in lay terms about cholangiocytes, about hepatocytes, about the difference between the cells, and where the specific mechanism is for PBC, if that makes sense, please?
Yes. Okay. Yeah. So the liver parenchyma has different types of cells. The liver cells have a lot of functions in your metabolism. Of not only when you think metabolism, a lot of people think food, digestion, but that's not all, right? It's everything that you intake will be eventually broken down and absorbed through sinusoids and getting to the liver. Once it gets to the liver, it will be detoxified. So medications, right? For instance, foods, everything will come to the liver to be detoxified. It needs the hepatocyte. They have a lot of enzymes that do all that stuff. Hepatocytes will also produce, they are in close relationship with the cholangiocytes. Cholangiocytes are the cells that line up the bile ducts. So they will produce the bile and secrete it in this duct canaliculi, and then the bile will be drained from the bile ducts. They start with the microscopic bile ducts that we call canaliculi, and they go, it's like an inverse tree, right? So they come from the smaller to the larger branches of this biliary tree until they drain in the large common bile duct, and from that, it's secreted in the duodenum, so in your small bowel, where it will mix with the food and help with digestion, right? So what happens in PBC is damage to these cholangiocytes. I mentioned we have the hepatocytes, the liver cells. They are actually functioning well until very late in the disease. So the damage is in the cholangiocyte. We have inflammation first. So lymphocytes, those are some immune cells, they go and attack your bile ducts. They get inflamed. With time, they kind of disappear. And as they disappear, we call that ductopenia, when we start lacking bile ducts. As that happens, then you don't secrete bile the way you're supposed to. The bile, there's some bile. I tell my patients, bile acids are like cholesterol. We have good cholesterol and bad cholesterol. So we have good bile acids and bad bile acids. And in PBC or in cholestatic diseases, we tend to accumulate some of these bad bile acids that can cause damage to the remaining cholangiocytes or bile duct cells, right? And yeah, damage to the cells that line the bile ducts. So we have accumulation of bile salts will be called cholestasis. So we have inflammation, we have that cholestasis, and over time this causes scarring, because scarring is how the liver reacts to any injury. It doesn't matter if it is fat, if it is alcohol, if it is autoimmune, if it is genetic, right? Over time, that damage, the way the liver tries to regenerate, as you all have heard, is by secreting collagen. You know, when you have a cut that you heal, that wound forms a scar. So that's that scar tissue is collagen, and it builds up in the liver. So as the scar tissue starts to build up, we go from 0 to 4. 0 is when you don't have excess scar tissue. And then 1 is very mild, 2 a little bit more, 3 and 4 is what we call cirrhosis. And the liver starts looking bumpy from all this scar tissue that builds up in the liver. This in a nutshell is what happens in PBC.
Perfect. Thank you so much. That is a fantastic summary. And I think, again, for people that are new to this service, that are just, this might be their first or second online question and answer session that they're watching.
You know, it's important. Sorry to interrupt, Robert,
No,
but I
please.
think in late terms, all this is happening at a microscopic level in PBC, right? The damage is in the tiny bile ducts that we would only see if we were to get a liver biopsy.
Yeah.
So if you take a picture of the bile ducts in a patient who has PBC and nothing else, it will be normal. MRI of the bile ducts, normal. You don't see it. It's only at the microscopic level that all that damage, the inflammation is happening, okay? And the bile duct loss, only at the microscopic level.
Thank you. That's really helpful. So, I mean, I've seen the slides, and a biopsy is 1/50,000th of the liver or something like that. Do you know off the top of your head, we're just talking now, do you know off the top of your head how many times that is magnified so that you can see what's going on a slide in a microscope? I don't know.
At least 40 times in the low power, up to 200 times in the high power. Yeah, it has to be magnified a lot for us to be able to understand. And we put special dyes to identify the different types of cells. We put special dyes to identify the scar tissue building up in the liver as well.
Okay, perfect. Thank you. Okay, next question, if I may. So again, staying with the stomach. So we've got somebody who's a swollen stomach, constantly itching and feeling sick. Food seems to stick in the throat. Also has chronic kidney disease. But the question is a swollen stomach normal with PBC? And then there's another question, which is what is the lifespan of this condition? So let's talk about the swollen stomach first, and then I'll come to you and talk about lifespans, if that's okay.
So swollen stomach is a term that it's a lay term, right? And it can mean different things. From the patient's perspective, it just means that you feel distended. Now, that can be, from the doctor's perspective, that can be feel just because your gut has a lot of air, or you feel more bloated, right? Or it can be water in the belly. Those are two different things. And many times the patients will come to me and say, I'm swollen or I'm inflamed. And that can mean different things. We have to do more tests to understand what that really means, what's happening. So is a swollen stomach common in PBC? Not at all. This is not a symptom of PBC. Okay. Now, if you have cirrhosis that is advanced, late stage, decompensated, you can retain water in your belly. So that is a symptom of cirrhosis that is advanced if there is water, okay? Could be PBC, could be anything else that causes cirrhosis. But again, when you mention a swollen stomach, if you don't have cirrhosis, then it's probably just, it can be, bloating is a very common symptom in GI. It can be so many things if you're not digesting well, if you don't have the enzyme to digest milk, for instance, people can be bloated and have diarrhea, or sometimes it's irritable bowel syndrome. There are bacterial overgrowth. There's so many things that can cause bloating. That's a whole other issue. Okay.
Yep.
So it's important to differentiate. If you are distended, your doctor will have to dissect this a little bit and say, okay, is this just gas that's common, it's very unpleasant, but it's not a bad thing from the doctor's standpoint. It's bad from the patient's standpoint, if you understand what I mean. Now, water in the belly means advanced disease, and we need to do more workup. Food getting stuck in the throat is also not a symptom of PBC. However, I want to call your attention because many people suffering with PBC also have what we call Zika syndrome, dry eyes and dry mouth, right? And if you have really bad dry mouth, it will be hard to swallow. Okay, so I've seen that many times. And by treating the dry mouth, you can improve the swallowing process. That's one thought. The other thought, there are other autoimmune diseases that can be associated with PBC, so not caused by PBC, but seen more frequently in people who suffer from PBC. And some of these diseases, like scleroderma, for instance, could cause change in the motility of the esophagus and cause food to be stuck in your throat or esophagus, okay? Thyroid problems. So it needs to be investigated. It's not a symptom of PBC, but we need to talk more, dissect the symptom and investigate it better.
Okay, perfect. That's helpful. Thank you. So one of the things that I forgot to say right at the start was that what we're doing here is providing general medical information, and we're not specifically giving anything that would replace a consultation or anything that would replace the conversation that you need to have with your own clinician. So again, this is just general medical information, certainly not medical advice in any way, shape, or form. So again, just to reiterate that point. Okay, Cynthia, can I ask you, PBC and HRT? So somebody's just been newly diagnosed with PBC just 2 weeks ago. So this is obviously a huge time right now, and there'll be a lot of fear, a lot of uncertainty. There'll be an emotional aspect to where they are right now. So if this is you, firstly, welcome to the community. So glad that you found us, and welcome. And please feel free to ask as many questions as you need. And if you are not in the UK, we can set up a Zoom time or anything else to go through your questions one by one. But we're delighted that you're here. So your question is somebody who's newly diagnosed and they're wondering if they can continue their HRT.
Yes, I would. Again, we always want to know the stage of the disease. If there is what we call synthetic dysfunction, if the liver is not working. Remember, I mentioned liver cells and bile duct cells. Only in very advanced disease, the liver cells will stop working in a patient suffering from PBC, right? So as long as liver function is good, and we usually don't have a problem with HRT. In the beginning, there were concerns because estrogen by itself, even healthy people who take estrogen, can develop cholestasis, the accumulation of bile salts and stuff. So there was concern that by giving this to somebody who already has a cholestatic disease, it could cause worsening of the disease. But after decades of following patients like you, we have not found that. So I don't tell anybody to stop HRT because they have PBC. So okay to continue.
Okay, perfect. That's helpful. We've had a couple of follow-up questions, which I love because that tells us that it's a live conversation. And it also tells us that people are listening, which is great. So follow-up question number one. So this is brand new information to somebody in terms of good and bad bile or bile acids. So can you explain how OCA and URSO work in the context of good and bad bile? That's a nice, easy question for you.
Yeah.
That's a cracker.
Yeah, it is and it is not, but I will break it down.
Okay.
And of course, things are not as black and white as I am, just saying to you, this is to facilitate. Oh, hold on, I pushed a button. Oh, here you are. Okay, it's not as black and white, right? But URSO is a good bile acid. So when we give URSO, this is a hydrophilic bile acid. What does that mean? It's a bile acid that it's more fluid. It helps with the bile flow. What does URSO? URSO has a lot of actions. Sometimes we say there are so many that maybe it's because we don't fully understand, but it does a lot. It's a good bile acid. It improves the flow of bile. It has some what we call immunomodulatory action, so it slows down your immune system a little bit. It's not like prednisone or not an immunosuppressant, but it modulates a little bit, decreases production of immunoglobulin M, which we know is increased in PBC. It's secreted by the B cells, right? It decreases cell death, apoptosis. And okay, I mentioned this inflammation in PBC happens in the cholangiocytes, right? Now, how does that happen? When the cholangiocytes, there are many mechanisms, but the cholangiocytes, when they die, we call that apoptosis, they express on the surface a protein that is the epitope, that is what the antimitochondrial antibody will bind to, okay? So every time there is more cell death, there is more of those proteins being exposed, more of the inflammatory reaction occurring because the antibodies will go and bite and connect. So urso is a drug that also decreases apoptosis. It decreases the cell death and supposedly more. It decreases the exposure of this epitope to the antibodies. So there are a lot of good actions with UDCA. This drug is the only one which has been shown to improve survival, period. The others are following, and pretty soon, hopefully, we'll have better data. As it is now, urso has been shown to improve survival in patients with PBC. That's the only one. The others are suggestions. Okay, OCA acts through a whole other different mechanism of action. It targets an antibody called a receptor called FXR, farnesoid X receptor. And by doing that, it decreases the production of bile acids, good and bad, but especially the bad. And it has also anti-inflammatory actions, and it may also be anti-fibrotic. What does that mean? It may reduce the production of that scar tissue that we were talking about. Okay, this is shown in animal models. In humans, we are connecting the dots. We're getting there.
Okay, no, absolutely.
Okay.
Thank you. And so we've got a question that says, can you give any information on the long-term effect of taking obeticholic acid? Now, this is a hot topic because, as you know, the PBC community, we're looking at clinical trials, we're looking at the needs of regulators. OCA only has a conditional approval at the moment. So with all of that context, what can you tell us about the long-term effect of taking OCA?
Okay, so the reason for the conditional approval is exactly because in the clinical trials, what we were able to show is improvement in alkaline phosphatase, and that's great because alkaline phosphatase, the higher it is, the worse it is, right? It's high alkaline phosphatase is associated with impact on long-term outcomes. So we want medications that will lower the alkaline phosphatase, and OCA does that. That's why I got an approval. Why is it conditional? Because the clinical trial has not shown yet that OCA improves survival. So the FDA says, okay, let's give you, and EMA will give you a conditional approval until you show me that you have the same long-term benefits of improving survival. Now I think we are eating by the borders because look, somebody also asked a question, what's the progression of the disease? What's the lifespan of the disease? This disease progresses slowly over decades. So for us as investigators to show that a drug improves survival, I would have to follow one of you for 10 years, 20 years to show a change in survival. And that's just not feasible. That's why we use surrogate markers, right? But we also eat by the borders. What do I mean with that? Well, you have heard about the Globe PBC score, which is a mathematical model that we can use to estimate survival, or the UK PBC score. Those are mathematical models that scientists come up with to estimate survival in 5, 10, 15 years. So I can tell you that if you take OCA for the studies now have gone to 5, 6 years, that if you take OCA, you improve your numbers on those scores, which probably indicates that improves your long-term survival as well. But that has not been shown in a prospective observation. So we have data when you compare patients who have been on OCA for 5, 6 years to those who have not been on OCA from the UK PBC population, so those of you in the UK, or the global PBC, what are those? Those are registries of patients, so just registries. So you're just taking your urso, going along with your life, and not taking any additional medication. So we have data from your doctors from 5, 10, 20 years of follow-up. So we use that real world information to judge, to compare to how patients on OCA were doing.
Yeah.
And that comparison showed that patients on OCA had fewer events of deaths or transplant. So again, eating by the borders, we're little by little showing that yes, if you're on OCA and you respond to it and you stay on it, your survival may improve.
Okay, perfect. Thank you. And just while we're on that question, I think there is data now that's more readily available that both OCA and URSO improve histology within the liver. Can you say something about
Yeah,
that, please?
there is very little though, Robert.
Okay.
I've mentioned out of the POISE trial of 200 patients, there were maybe 10 pairs of biopsies before and
Okay.
after, of which 5 showed some improvement. So that's why sometimes we ask if you would be willing to have a liver biopsy as part of the trial, even though it's optional. It's for us to be able to show these hard endpoints. But we have very little data, to be honest.
Okay, perfect. That's helpful. Thank you. The other follow-up question, again, going back to diet, if I may, Cynthia. So because they've got Hashimoto's as well as PBC. Now, again, you spoke earlier about how common it is to have another autoimmune condition
Mhm.
with PBC. But the question is, with regard to probiotics, there doesn't seem to be a consistent message. So, with PBC specifically, with PBC and Hashimoto's, do we know, is there anything we can say in terms of our knowledge about probiotics helpful or not?
There is nothing to make us think that you cannot use probiotic if you have PBC.
Okay.
There's no data that it helps, and there's no data that it harms you, and there shouldn't. There's no reason to believe it would cause any harm.
Okay.
I'll make a parenthesis here to talk about supplements, can we? Because I know
Yeah,
this is
please.
a
Yeah. Yeah.
question many patients with PBC and other diseases ask me about. Can I take this or that supplement? And sometimes patients may get a little mad with me because I tend to discourage that. It's not that I don't believe that something that is natural could be good. It could. The problem is those supplements, they are not regulated by any agency. In the United States, that would be the FDA. I guess in Europe, that would be EMA. I don't know what the UK agency would be, um, because they're not Europe. Um, there is no regulator.
Yeah.
So anybody can say, let's say Silymarin or milk thistle that many of you take. There is data that Silymarin could maybe be a little bit anti-inflammatory or antioxidant, possibly. That's as far as it goes. Won't do much more than that. But it's safe. Silymarin is safe. It doesn't harm you. The problem is anybody can say, okay, I'm gonna put Silymarin with a little bit of this or that, and they can say, okay, in this capsule you're gonna have 200 milligrams. God knows how much is in there. So actually, the NIH in the United States did a study. They took a bottle of milk thistle and they opened 100 capsules, and they looked at the concentration of silymarin in each one. And you know what? Each capsule had a different concentration. You could have 200, 400, 1,000, God knows. And God knows what it's mixed with. So, and that's silymarin, which otherwise is a safe one. Imagine the ones that may not be safe, like
Yeah.
curcumin in a high dose has been, or that's turmeric that many people like to take, in high dose has been shown to cause liver failure. So yeah, in general, I discourage because we don't know what you're taking. And remember, everything that you take will go to your liver, will be exposed there in your liver.
Yeah.
So unless you have a very good rationale about the source, I tend to discourage. Probiotics are a different situation. I don't consider probiotic a supplement. And there is no reason to think it's harmful in any way in PBC
Okay,
or in thyroid disease for that matter.
all right, that's helpful. Thank you. So we had a specific question about something called Easy Flex, which I don't know what that is. So again, would that
Exactly.
be
I
under
have no
that?
idea what
Okay,
that is.
perfect. Okay,
I'm
that's
sure
helpful.
there are multiple ingredients. So my advice is look at the label, whatever supplement you're interested in. Okay, look at the label. Make sure you read all of them. You can do research on your own and Google, or you can take that label and send to your doctor and say, "This is a supplement I'm interested in. Do you have a problem with any of these ingredients?" That's the least that we can do.
Okay, perfect. Thank you. This is a question that comes up regularly, and it's the situation where somebody can have good blood tests or liver tests and yet still feel affected in terms of symptoms,
Mhm.
and how that doesn't seem to make sense. Can you talk a little, please, about the relationship between your liver tests and their results, and then the actual symptom burden and your day-to-day quality of life, please?
Yeah. Thank you for that question. And see, remember when I mentioned regarding the meetings, how we can educate other physicians? This is one area that we're constantly trying to educate uh, providers and patients, because there is no relationship. You can have your PBC very well controlled in terms of the disease. Your alkaline phosphatase can be normal, and yet you can be itching, or you can have a lot of fatigue, or even the sicker symptoms that I mentioned, the dry mouth and dry eyes. So there is no direct relationship. It's possible as the disease is more advanced, people may tend to be more symptomatic. Right, but that doesn't mean looking at presence of symptoms doesn't mean that your disease is not controlled. So there is a disconnect, and many times I can hear your frustration. You're going to go to your doctor and say how bad you're feeling, and some doctors will say, well, but your numbers are good, so you shouldn't be feeling that way, as if they don't validate what you're feeling, which is absolutely wrong. That's where we all need to educate each other here. So no relationship. And there are options, especially for the itching. There's so many options to control the itching, uh, regardless of how the PBC itself is doing. For
Yeah.
fatigue, it's more of a challenge for us because we're still developing and we don't fully understand the symptom, what's causing it. And when we don't know what's causing something, it's hard to target and treat it. But still, there are things that we can discuss and offer on the day-to-day to help you overcome those symptoms as best as we can.
No, absolutely. That's helpful. Thank you. I think we're allowed to share this. Nobody's told me we're not allowed to share this, but we're sponsoring research at the moment to look at developing a CGI, and I can never remember what CGI is. Global impression. I can't remember what the C is, but basically it's a scale of 0 to 7, where we're looking at each domain within the PBC 40, validated scale, and starting to measure the symptom burden with the hope that once we can measure it, we can then start to measure changes. And you can all hear that my dog is absolutely delighted that we're doing that. So apologies for that. Right, I'm going to ask you a question. I'm going to mute, and then I'm going to kill my dog. So the question is, somebody has Raynaud's, Hashimoto's, and now they have, I'm going to say, Libido reticularis. No idea how to pronounce that. So again, I'm open to your corrections. Do we know anything about it? Is it linked to PBC? Is there any information you can give about the condition, please?
Yeah. So livedo reticularis is a vascular condition. It's usually linked to some other autoimmune rheumatologic disease. It's not associated with PBC. It's not caused by PBC. But PBC is associated with a number of other autoimmune conditions. So things like rheumatoid arthritis, lupus, these patients may be at higher risk for livedo, but it's not a symptom associated with PBC. So if that's what you have, your doctor should be investigating for these other autoimmune rheumatologic conditions that can be associated with livedo.
Okay, perfect. That's helpful. Thank you. Okay, next question for you. So we've got somebody who has AMA M2 antibodies, 1 in 40, Now they're 28 and they're pregnant, so they're obviously when you're pregnant, you tend to have more tests, and a lot of things get picked up coincidentally. So I guess there's a general concern. So the question is there anything that you can tell them in terms of what this result means? So being AMA positive, there is a yellow tinge to the skin. We don't have any idea of what the the liver tests say, but what can we give
Yeah.
information-wise to this?
Yeah, we need a lot more information to answer this in details. AMA is not a test that we order in a pregnant woman just because. Now, and again, I don't know your personal situation, but there is a condition in pregnancy called intrahepatic cholestasis of pregnancy that is characterized by itching. And usually it starts in the third trimester, although it can start on the second and more rarely on the first trimester, but usually it's a third trimester disease. Um, so it's possible if you have, but interestingly for ICP, intrahepatic cholestasis of pregnancy, you're itching, there's no rash, just like in PBC, but typically the liver enzymes, what we see is AST and ALT are elevated, not so much the alk phos. But it's possible that this person had itching and the doctor ordered an AMA as part of the investigation for itching. I don't know this scenario. Or maybe your alk phos is up and they were investigating. I don't know. Now, in PBC, let's focus. So I don't know what it means just to have this. Why did they do that, and what the other liver tests mean? And so having a positive AMA in normal liver chemistries does not mean that you have PBC. I can tell you that. I would say that what the data shows is about 15, 16% of patients with a positive AMA will develop PBC within the next 5 years. Okay, so if you are one of these people with a positive AMA, normal alkaline phosphatase, I would say at least once a year we need to have liver tests done and make sure we follow. If the alk phos ever goes up, we make our diagnosis. We can also check a GGT, transaminases, to see if there's something else that needs to be investigated. Okay, so that's one scenario. Now, if you have well-known PBC before pregnancy, what happens during pregnancy? You know what's interesting? First of all, there are few studies. You should know that because that's rare. But we know from small studies that the AMA levels can actually drop during pregnancy because
Okay.
in pregnancy, your immune system, there's a shift in your immune system. And many autoimmune diseases tend to get better during pregnancy. And the antibody levels can go down, immunoglobulins go down. And then late in the third trimester and after delivery in the postpartum, they go up again. So many times PBC flares up or opens up after pregnancy in the postpartum period. Usually during pregnancy, people do really well. PBC does not really increase your risk in pregnancy. Okay, you may have more itching, but that's it.
Okay. Perfect. That's helpful. Thank you. Okay, I've got so many questions coming in. So where would we go next? Actually, just while we're on pregnancy and babies and that kind of thing, but a really cracking question here. So, I have PBC, not me personally, but the person asking the question. Their child
Got
is 9 months old and has raised ALT. Is this something that could be related to PBC, and should I get him checked?
No, it's not PBC. PBC does not affect kids. And PBC does not cause just an isolated ALT elevation. So, no, 8 months old they do not have PBC. That's something else. I think the pediatrician and the neonatologist can go over with you what other investigation may or may not be needed. I don't know the details, but it has nothing to do with PBC.
Okay, perfect. That's helpful. Thank you. Got another great question for you. So, somebody has decompensated cirrhosis caused by PBC. Now, they were only diagnosed 2 years ago. They've been on URSO for 1 year, and their latest labs are their ALK phos, AST, ALT are all back to the normal range, which is great news. Absolutely delighted. The question is, how will this benefit the cirrhosis?
Yeah. Wow, great question. In general, any liver disease When you treat the cause and you control the cause, you slow down the progression of the disease, okay? And I'll give you examples. So if you have hepatitis C and cirrhosis, and you treat and eliminate the hepatitis C, you decrease substantially the chances that that person will ever decompensate or have cancer in the liver. If you have fatty liver disease and cirrhosis and you lose significant amount of weight and you control the diabetes, blood pressure, the cholesterol, fibrosis slows down, may regress a stage or two. Right? Autoimmune hepatitis, you treat the autoimmune component, you slow down, you decrease the risk of decompensation. So treating the underlying disease and getting under control is the most important, is very important, okay?
Yeah.
What's the caveat here? You're describing already somebody who has decompensated. So that can be a vast, there could be what we call a child B, a child C, ascites, varices, bleeding, encephalopathy. So some of these, when you reach a certain point, you may not improve very much just with the ursodiol and responding to the treatment. And liver transplant may be a consideration. Again, I don't know the individual case, but certainly controlling the disease helps your chance of recompensating. We now know, in the past, when we said decompensated cirrhosis, that was like a death sentence. It's no longer like that. We introduced the term recompensation when we control the underlying disease and the event, the diseases tend to recompensate, and you can go back to that state where the ascites is controlled with diuretics and a low salt diet. If you have encephalopathy, taking lactulose will control that. If you have had a bleeding, bending the varices and giving you beta blocker will prevent you from bleeding again. And all of a sudden you go back down from a MELD of 17 to a MELD of 10, and you live happily for a long time before that happens again, if ever. And I mentioned the word MELD. I realize you may not know what that is. So MELD is a mathematical model. It's a model for end-stage liver disease that calculates exactly the likelihood of bad complications when you have cirrhosis. And that helps us determine when you need a transplant or not. So my point is, you may have somebody who have high MELD, so it's fully decompensated, and then we treat the underlying disease, everything else can improve again.
Okay, perfect. Thank you. I'm not going to talk about MELD.
Huh? You don't want to talk about MELD?
I'm not going to talk about MELD. I'm
It's
not,
okay. I'm here to answer questions.
even with all the changes. Okay. Question is, somebody has started sweats about 5 months ago, and it seems to be just before menstruation. They have night sweats, and now they're saying that this is suddenly happened since taking urso. So the question is, could this be an urso side effect, and can urso affect hormones?
I haven't seen that as a side effect to urso, and again, I don't think it affects hormones. So I would investigate other things, infections,
Yeah.
but no, I don't think that's related to urso. It's a very natural reaction if we start a new medication or there's a new milestone in our lives, we incorporate that. It's a temporal correlation, right? So at the same time that you started this medication or around that same time you notice this or that symptom, and we tend to correlate them both. That's a useful discussion, but we have to be careful. It's not always true. I have not seen that as a side effect. I'm not aware of that being a side effect of urso.
Okay, perfect. Thank you. So we've got a
And
question
again, I just want to emphasize, urso improves survival. So even if in your mind you still have that doubt, if it's something that you can tolerate, continue on urso while you do your workup, okay? Don't give up on it. Maybe lower the dose and go up slowly with your doctor. Don't do it on your own. Ask your doctor. My point is, don't give up on it too soon, because this
Yeah.
is the best drug in this disease.
No, perfect. Thank you very much. That's helpful. I've got a question about amlodipine, which is a tablet.
Amlodipine.
Thank you. So you keep me right.
It's a blood pressure.
It's a blood pressure tablet. So I guess the question specifically is, we have somebody who's 83 and has cirrhosis, and their question is, I wonder, is it safe to take this when you have PBC? So if needs be, we can separate that into with cirrhosis and just PBC, or just in general. I'll leave that in your capable hands.
Well, amlodipine is safe for PBC.
Okay.
And cirrhosis, it's usually safe as well. So swelling is a common side effect of amlodipine. Swelling in the ankles is a very common side effect, even if you're 50 and you don't have cirrhosis, okay? You may be more prone to swelling when you have a certain degree of liver disease. So you just talk to your doctor to see if there's an alternative. There's so many blood pressure medications, so there may be some, you may be a candidate for another medication that won't cause this. So this is not happening because of your liver disease, and it's not PBC, cirrhosis. It's not. We see that with amlodipine regardless. Okay.
Okay, that's helpful. Thank you. We've had a great question about AIH and PBC. So, and I have my own thoughts about AIH and PBC, and I'm going to share those thoughts with you, and then you can correct me or slap me about the head or answer the question.
Mm-hmm.
So, in my conversations with patients,
Okay.
it feels that PBC and AIH overlap is overdiagnosed, but actual PBC with actual AIH overlap feels underdiagnosed. Because when you look, so the statistics tell us that around about 10% of patients will have that overlap. Whereas there seems to be lots and lots of patients out there that have been given that diagnosis. So could you perhaps talk a little about PBC and AIH overlap, the fact that now we're talking about PBC with features, all of those kind of things, and maybe give some proper data as opposed to just my biased view when I listen to patients, please.
No, those are good questions. I think there's a lot of conflict, I would say, even among the experts. People don't necessarily agree on that. So it's not just patients, it's everybody. And when that happens, it's because we don't know enough, right? But let me tell you what the facts are.
Please.
Or what we understand. Yeah, we have very clear consensus on how to diagnose PBC, right? We all should know chronic elevation of the alkaline phosphatase, positive antimitochondrial antibody, or PBC specific ANAs, not just any ANA. And there are certain specific features on the liver biopsy, inflammation of the bile duct, specific type of inflammation. We need 2 out of 3. So that's very well established. Now, autoimmune hepatitis is it's a different puzzle.
Yeah.
There are no set of criteria like that. What is it characterized by? So in PBC, you have an immune attack against the bile duct cells. In autoimmune hepatitis, you have an immune attack against the liver cells. Remember those hepatocytes I mentioned about, different types of cells, okay? But we don't have one antibody. Well, we have some antibodies that are more specific, but not very common. The most common antibodies are the antinuclear antibodies or the smooth muscle antibodies. And those two are so common in healthy people. So a quarter of the general population will have those antibodies. What is the most common mistake that I see? I have a ton of patients refer to me for autoimmune hepatitis when all they have is a positive ANA or a positive smooth muscle. So to make a diagnosis of autoimmune hepatitis, you need a combination. It's not as clear as PBC, but you need a combination of those antibodies with elevated IgG levels, immunoglobulin G, and biopsy showing attack on those liver cells, not bile duct cells, the liver cells.
Yeah.
And there are specific features in the biopsy that we look for. Okay. Different from PBC, to diagnose autoimmune hepatitis, I believe, and most experts, I can name one or two who disagree, but most experts agree that you need to have a liver biopsy to confidently diagnose autoimmune hepatitis.
Yeah.
Okay. So why is Robert saying that overlap? What's the overlap when you have features of the two diseases? Okay. So some believe that the two diseases are a continuum, part of a continuum. So it's actually the same disease, different spectrum. You can start at the bile ducts and then at some point get damage of the liver cells, or start at the liver cells and then get more damage at the bile ducts. We don't know. It's probably true. I believe that it's part of the same spectrum, but you can present first with one, first with the other, or with both at the same time. Okay. So why does Robert say this is overdiagnosed? Because people will diagnose PBC, clearly we have the criteria, and then they have a positive antinuclear antibody or a positive smooth muscle antibody or even a high IgG. And then usually this is not a patient's mistake, usually it's the clinician, will look and say, ha, PBC plus ANA equals autoimmune hepatitis, and that's wrong. Okay, that's why. So I think it is overdiagnosed. I don't know that the true one is underdiagnosed. I don't know that I agree with that. But
Okay.
I agree that it's overdiagnosed and therefore it's mismanaged because they will do that in the community. They will not do the liver biopsy. They will say, what do I need a biopsy for? The smooth muscle is positive. Well, who cares? You know, I know a lot of people who are normal and have a positive, smooth, healthy, and have a positive, smooth muscle.
Yeah.
So, and it's a very important diagnosis because if that's what we believe that you have, additional therapy will be necessary. It's not just urso or ocaliva or fibrates. You know, you need to immunosuppress the person. So it's a very, once that is, if that's you, if somebody told you that it may have an overlap, you say, okay, I think that needs to be confirmed. Is that seen in my biopsy? So that's, you should feel empowered to ask your doctor, okay, how did you make that diagnosis? I'm okay, I'll follow your recommendations, but I'm gonna work with you. Well, why are you saying that? Does my biopsy show damage to the liver cells? You know, you wanna know what's happening there. So be empowered, know the data, and if the diagnosis is confirmed, then we'll treat. Another scenario where overlap is suspected is when the ALT and AST are elevated. However, in PBC, I can see that. And the higher the alk phos, the higher I can see AST and ALT. So the first pass for treatment should be urso. Then after 3 to 6 months, we can repeat labs, 3 months. If the transaminases, AST, ALT are still disproportionately high, then a consideration could be given to doing a biopsy to see if there is damage to the liver cells, right? The autoimmune component. That's a long explanation.
No, perfect. So just to let you know, I have now got house on my Cynthia Levy bingo card. We've had lay terms, we've had data, we've had science, and we've had patient empowerment. So thank you. Right. So thank you very much. Yeah, it just, you know, it's a pleasure to work with you. And again, to have that science, the data, the clinical aspects, but then for one of your major focuses, and we've known each other for years, is that patient empowerment part and being part of an active collaboration, an active partnership. You know, we hear many times that patients are people, and we often forget that doctors are people too. And you know, and so, but again, to be honest and say, even within the community, we don't actually fully agree on this. And there's some thoughts on this, and there's some thoughts on that. And I think it's really important and powerful for patients to hear that these kind of conversations are still happening, and that we are, as a community, working harder and harder to get those answers.
Yeah,
So again,
absolutely. There's
Thank
some doctors who don't believe at all that overlap exists.
you.
And I know an example, and others will diagnose it too quickly. So I would just say this has a long-term impact for you in your life. So if there's any question, if this comes up, just ask, okay, why? What can I
Yep.
do about it? Do I need a second opinion? Are you comfortable with that diagnosis? Is that confirmed in my biopsy? Do I need another opinion? That's okay to ask.
Yep.
Yeah,
Perfect.
we're people and we're wrong many times.
So, okay. Thank you. All right. Here's a great question. So again, somebody in really simple terms, they've had a long, long journey and it's taken them many years to be diagnosed. So the question kind of alludes to, is it common to have something as serious as PBC? And we can look at that phrase in itself. But is it common to have something like PBC without symptoms for years?
Absolutely, yes. Most people with PBC will have no symptoms, right? So it can go quiet for a long time. The elevation in alkaline phosphatase can be mild. Some doctors can put it off and say, "I don't worry about it. This is only a little bit elevated." Yes, absolutely, no symptoms. Which is a wrong thing to do. It's not right. Just because it's mild doesn't mean that it doesn't need to be addressed. But I'm just saying that's a common scenario. I've seen it over and over again. So yes.
Okay, wonderful. Thank
With
you.
and without. So breaking it down a little bit more,
Yep.
and again, because you're not just PBC, right? You're not just the liver or just PBC. We see that with all the liver diseases. We can see full-blown cirrhosis with completely normal liver chemistries, meaning AST, ALT, alkaline phosphatase, platelet count, everything normal, no symptoms, okay? Um, Cirrhosis already on biopsy. So yes, you can go silent and quiet for many years.
Okay, perfect. Thank you. Um, okay, we've got another question. So again, somebody who has diagnosed for a while, also responder. But their question is, can their anemia be linked either to PBC or to malabsorption?
Okay, great question. Um, did you say well-controlled PBC or
Also responder.
also
Um,
response? So,
yeah,
so let me break this down.
please.
Anemia and PBC, right?
Yep. Yep.
So anemia is not a symptom of PBC, but I can see it in especially to well, every young, if you're still having your period, you could lose iron and have anemia because of that. But specifically, if you have cirrhosis, so patients with cirrhosis can have not only anemia, but a drop. So a drop in all the cell counts. We can have low white count, low red cells in anemia, and low platelet count. We can see all that as a result of cirrhosis with a big spleen, which we call hypersplenism. So
Yep.
it can be. Now, if you don't have cirrhosis, if you don't have what we call portal hypertension with that big spleen, then you shouldn't have anemia due to PBC. We have to start thinking about other causes. Okay. One other cause that is seen a little bit more common in patients with PBC than in the general population is celiac disease. So
Yep.
celiac is the intolerance to gluten. You might have heard about this. And people with celiac don't absorb the iron well in the small bowel, and they can have iron deficiency anemia. Okay. Other than that, PBC itself should not cause anemia. Like, if you have chronic thyroid disease, that can cause anemia. Um, so thyroid, celiac, nutritional deficiencies. If you're vegetarian, you may not have enough iron. Um, Autoimmune gastritis can cause B12 deficiency that causes anemia. But PBC specific, only if you have cirrhosis advanced.
Okay. Perfect. That's helpful. All right. I've saved the best question for last. Now, I have a vested interest because I'm here at a patient support organization. So we talk
Mhm.
about the emotional and psychological aspects of living with PBC almost every single day. So the question is, and I'm going to open it up. So there's a very specific question, but I'm going to open it up very slightly for you, Cynthia. So my question for you is stress and anxiety. Does it have any implications for PBC, either in terms of symptom burden or in terms of progress? What are your thoughts on that, please?
Well, that's a huge problem, not just for PBC, right? For all of us, it's the times living, and I think PBC increases that issue because it's inherent. If you have a chronic disease, it's expected that you're gonna, to some extent, feel stressed and anxious, and you don't know what's gonna happen. That's why it's important to have this open channel of communication with PBC, patient support organizations who are founded in science, like PBC Foundation. They can answer the question, isn't your concern, and be in touch with your physician, your clinician. It's not that PBC causes anxiety directly. It doesn't cause a problem in your brain that causes anxiety, but it's just the fear of the unknown and the future and what the future holds for me. And these times of uncertainty that we're living in. So altogether, does stress make your PBC get worse? No, but there is no data for that. I do think that stress affects your immune system to some extent, but there's no data to this point that if you're super stressed at work or stressed about your disease, that your PBC will progress faster or will stop responding to the treatment. There's no data about that. Okay, so those are separate problems. I think we'll treat the PBC with the drugs that we have available, and you need to open up about the stress and anxiety so we can help you manage that. We can help you cope. There are a number of strategies with mindfulness and sometimes medication, pharmacotherapy, that can be used to help. I was just made aware a couple of weeks ago, University of Alberta, Canada, they have a study going on. Puneta Tandon is the principal investigator for that. I think Mark Swain might have been involved to some extent. If you go online, and they have a QR code that you can log in, they have two things. One, a lot of information about liver disease online, from diet to what exercises can I do, how do I do this, all there to help you.
Yeah.
General, that's not PBC specific, but they're also doing a study for mindfulness in PBC to see exactly patients living with PBC who are suffering from stress and anxiety, depression, if these interventions help your symptoms. So go online, they're looking for patients to participate now if you want.
So I'm delighted that you know about that, because I know that Gail is the lead at the Canadian PBC Society up there in Toronto, and I think, are we seeing you in June?
In 2 weeks. Are you going to be there?
I'm going to be there. So we've got our summit first, and then I'll be over for that one. But Gail has led some amazing work. They've done a small scale study that says that mindfulness and self-care and all of those things have a huge positive impact on symptom burden and that kind of thing. So yes, if there are more patients who want to get involved in this study, I do think you can do it remotely, as far as I'm aware.
Yes, it's all remote.
Yep.
All online.
So again, so please do get involved in that, and not only be part of the answer, but maybe experience that improvement in your own quality of life through your involvement in that study, which would be amazing.
Exactly.
So, okay, right. Some wonderful questions. Thank you so much. If I may, Cynthia, I'm going to take this time just to put a couple of plugs in, if I may. If you are with the foundation, if you're registered with us, if you're using the app, there is a survey that we are taking place now, which we are asking you to be part of. This is giving us your views on clinical trials. So Cynthia and I have talked about this very loosely today in terms of what we're trying to achieve as a community. And it would be great to know the patient views, patient experience of clinical trial participation, so that we can then incorporate those views into the conversation. And the other thing I'd like to say, Cynthia, to you apologized right at the start for changing the time of our Q&A. I would actually like to thank you for changing the time, because what that has done is actually opened us up to new people that are maybe seeing this for the first time, who maybe not encountered us on Facebook or you know, are seeing this, because it is a completely different time, particularly those that are in the US and Canada. There maybe are mid-afternoon as opposed to early in the morning. So actually, for changing the time, thank you, and we're grateful. And it's provided us a new opportunity. Other than that, for everything you brought today, thank you so much. It's been a great session, and it's been great to work with you again. So thank you.
Thank you. Thanks for the opportunity. I hope I have clarified some of the muddy points, and my pleasure to join you. Thank you.
Yeah. Okay, it's been a pleasure. Right. So I'm going to talk to those on Facebook first. Thank you very much for joining us today. So we are back next week. Next week, we're actually going to have a Q&A on what we're going to be doing at the summit. So if you have any thoughts or questions about what we're doing at the summit, then please do come and join our Q&A next Thursday. Other than that, I will say thank you to the Facebook room first and bid you well. So I'll end that live video and then I'll finish recording.